Hello, Novia. Can we start?
Yes, we can. We're ready, Najee.
Okay, very good. Good morning, good afternoon, good evening. My name is Najin Yasrebi at UNICEF headquarters. We're with you today with the second webinar session on All-In to EndAdolescent AIDS. We will be sharing with you the experience from Jamaica. We have with us Ms. Novia Condell from UNICEF Jamaica office, as well as our national partners in Jamaica. My greetings to them as well. Without further ado, I hand over to Novia to introduce our presenters today. Novia, over to you.
Thank you, Najeen. And a warm Jamaican welcome to everyone who has joined us. We are really, really excited and very happy to be presenting our experience, and we hope you can learn from some of the things that we have been able to do through this really very valuable platform, All-In. And I'm not going to be long because we have a lineup of really good speakers who have been steeped in this experience since we began. So our first speaker this morning will be Kate Spring, who is Country Director for UNAIDS Jamaica, and she will be presenting the strategic importance of All-In. We also have Dr. Charlene Jarrett, who is Director of Monitoring and Evaluation at the National Family Planning Board, Sexual Health Agency. And I'm seeing my voice is faint. I'm hoping that that will improve as we go along. I'm going to try and make sure that all my... okay. Is that better? Are you able to hear me better, Marcos? So I'll just continue. Let me know if I'll do my best to fix as we move along with some of the technical issues. So once Dr. Charlene Jarrett has finished her presentation, we're going to move on to adolescent participation in the process, and that will be done by our adolescent representative on the All-In Steering Committee. That's Ms. Nikisha Black. And then Dr. Nicholas Kyers, who is the Senior Medical Officer at the Ministry of Health's National HIV Program, will be presenting on the implications of the findings of our rapid assessment and the way forward. And she will also be going into some of the lessons, the key lessons learned from the process. So we really look forward to a very good discussion after all the presentations have been made. So without any further ado, I'm going to hand over to Ms. Kate Spring from UNAIDS, and we'll be playing a little bit of musical chairs so that you can see and hear us well as this moves through. So our speakers will be moving to the seat I'm now in. But thank you. We look forward to the discussion.
Hello. Good morning. This is Kate. And I've got a few minutes only to put out the strategic importance of this work in Jamaica. All-In in Jamaica, it begins with a national development plan and Vision 2030. The first goal of which is a healthy and stable population. So this initiative is grounded in the national plan. The National Strategic Plan for Sexual Health and HIV from 2014 to 2019 recognizes adolescents and young people as vulnerable and calls for a collaborative approach across sectors with the focus on building resilience among key adolescent populations. The main challenge is that there hasn't been a strong strategic focus on adolescents. And this has prevented Jamaica from taking a much more direct approach to addressing the epidemic among the cohort, as adolescents are most often included among the 15 to 24-year age group. This status provides some opportunities, and Jamaica is capitalizing on this to develop an evidence-based case for investment in adolescents in keeping with global frameworks to which Jamaica is aligned, including what we're calling fast track and then the 1990 frameworks. In this platform also, we have a joined up approach that bringing all the sectors that are acting together to end AIDS among adolescents. So we would have international partners, we'll have but led by governments. The Planning Institute of Jamaica, the Ministries of Health, Education and Youth, in collaboration with civil society and adolescents themselves. The UN in Jamaica is committed to all-in at the highest level. Well, they said, sorry. The UN is committed at the highest level. So in Jamaica, it is on the joint team.
Press pound at any time to return to the conference. To request an operator, press *0. To request an operator.
Can you still hear me? All right, I'm almost done. So in Jamaica, the joint team on HIV has included all-in on its work plan for 2015. And all agencies in the joint team are key stakeholders in this process, and we have all responsibilities that link to the AIDS response for adolescents. But we continue to work on improving engagement even in the country team. And that's it. I hope that sets the stage for the details. Thanks.
Charlene Jarrett, the findings of the rapid assessment.
Morning.
Good morning, we can hear you.
We're trying to put up her slides on it.
Start with just a few brief slides on the general epidemic situation in Jamaica. Currently, we have a population of approximately 2.8 million, and we estimate that there are 30,313 persons living with HIV in Jamaica. Of that number, we estimate that 25% of these persons are not aware of their HIV status, and this is a proportion that has increased significantly over the past decade, where we've gone from over 60% not knowing their status to now having 25%. The epidemic affects the entire country. You can see from the map that's on the screen. The two most affected areas are our two urban centers, so the capital city, Kingston, also the parish of St. James. And if you also look along the top left-hand half of the graph, those areas in the darker orange, brownish color, those represent our tourist centers, and those are also areas that are highly affected by the epidemic. No problem. Okay. So next one. In terms of the impact on the population, for a long time, the epidemic was characterized as generalized, and we would find prevalence rates above 1% when we did our ANC surveillance. That's shifted a bit in the past few years, and from doing different surveys, we've found that we've really moved towards a concentrated epidemic with very high rates found among men who have sex with men, female sex workers, and homeless persons and drug users. What this slide also shows that while we have good data on specific groups, we have very limited data on adolescents, and we haven't looked closely at that group of the population, and most of the information that we have on adolescents come from surveillance data. And with issues in access to healthcare and testing, it's very limited data and really skewed by who has access. And so the All-In initiative actually was quite timely in that it now allowed us to begin to understand the epidemic among adolescents, which previously was a major gap in our surveillance system and in our understanding.
Is everyone able to hear us? Because I'm not certain that everybody can hear. I just need an indication that we're being heard.
It will be better if you can speak up a little bit.
Okay, all right, thank you.
So the All-In process, we really followed the guidelines and the recommended steps for implementing All-In. We started off with the process of the rapid assessment, and the first step was establishing a multi-sectoral steering committee. This committee was co-chaired by the National Family Planning Board and the Ministry of Health, which are the agencies with responsibility for sexual reproductive health in Jamaica. And the committee received strong support from the Planning Institute of Jamaica, the Ministry of Education, Ministry of Youth and Culture, Labor, Statin, which is our statistical institute. And also we have involvement from various civil society groups. Those organizations, civil society was more involved in the consultative process, which was a government-led consultation, data gathering, and we had broad participation from various stakeholders. We also had a process of reviewing and validating multiple data sources. A consultant was engaged to really lead the process to ensure that we were able to identify various sources of data, pull them together, and also do the necessary validation. We had focus group discussions with adolescents and young people, and I think the next presenter will speak a little bit about that process and how it was accepted by the young persons. And then finally synthesizing the data and the feedback into the dashboard. And I'll actually present that data to you now to show what are some of the take-home messages and the discoveries about our data and adolescents. Just a quick overview of the various data sources that were used for this process. We used the UN Population Division Demographic Estimates, the UNAIDS HIV and AIDS estimates coming out of Spectrum. We also had various local national surveys that were used. We had the 2008 Reproductive Health Survey, 2011 Mix, and the 2012 Knowledge, Attitude, Behavior and Practices Survey, which are our main sources for national indicators. We also had various targeted surveys. So we had a national MSM survey and a sex work survey, which were done in 2011 and 2012. Both were conducted using the PLACE methodology. We had various data coming out of our health information system. HATS is our HIV/AIDS tracking system, which is our surveillance data for our HIV cases. And the MCSR is our clinic data, so monthly clinical summary reports. So we were able to get various health statistics from that. And then we also had our focus group and consultations and reviewed a number of reports and various policy documents. So very broad data sources were used. So start to get into some of the actual data now. So just to establish the size of the adolescent population that we're speaking of. As I mentioned earlier, we're 2.7 million at the end of 2013. Of that, the estimated population of adolescents, 513,499. Of that, almost half are girls, and the remainder evenly split between boys and girls. And they represent 20% of the population. So this slide shows the HIV prevalence among adolescents and young. And as you look at the slide, you'll see that between ages 10 and 14, it's equal prevalence. So 0.1%, very low rate. Most of these cases are from vertical transmission. When you reach age 15 to 19, you see it begins to increase, 0.4% girls and 0.5% among boys. And this really shows with the onset of sexual behavior and other behaviors, you see where there is a significant increase happening. And as you move into the young youth population, it goes up to 1% among girls and 1.4% among boys. And this slide is one of the first findings that came out, as we started the data analysis. And for us locally, this was actually a very informative finding, because previously we had relied on surveillance data to understand the impact of the epidemic among youth. And in our surveillance cases, 4 times as many cases are reported amongst girls compared to boys. And so this is actually the reverse of what we assumed to be the burden of the disease among our youth and adolescents. And so this, at the outset, really set the stage for some of the findings that we were going. So actual estimated numbers of adolescents and young people living with HIV. So we have estimated 685 girls and 815 boys. So this slide looks at the number of adolescents newly infected with HIV in Jamaica. And in general, we've seen a decline in incidence of HIV in Jamaica. And this slide shows that similar picture obtains for the adolescents. We have reduced from 600 cases in 2001 to just under 300 cases currently. Based on this projection, we expect to see a continued decline. However, and this is assuming that the efforts that were in place to accomplish this decline will continue, we will achieve a further 55% decline in incidence. However, this will not help us to achieve the fast track targets, which is 75% decline in incidence by 2020 for us to see the elimination of adolescent HIV. And so for us, we'll need to think of some innovative, accelerated activities to actually move the work among adolescents and further reduce incidence. And this also shows that essentially the new infections in Jamaica will not be halted if we don't have targeted action on adolescents, because the rate of decrease is not sufficient to achieve the elimination targets. The estimated number of AIDS-related deaths among adolescents, I think this slide shows that this is really an area where we have done very well in terms of access to treatment, of having adolescents benefit from treatment. We have a very successful PMTCT program, and we have made treatment available to adolescents who were infected vertically, and also for adolescents identified who were infected otherwise. And so this really has been a great success, and this is an area where we need to have continued. And so the investments in treatment, it will continue to pay off if it is sustained, and be able to see the end of AIDS deaths among adolescents. Actual data now on the population size of adolescents in the key groups. We use the surveys I mentioned earlier, the MSM survey and the sex work survey. We use data coming out of that. We also use national estimates that were done for the adult population, and those were guided by global estimates in terms of the proportion of adult population that identified as MSM or had reported MSM behavior in a given period of time. So guided by those sort of global estimates and what we were finding in other local surveys, we estimated that there are 6,250 young men who have sex with men in Jamaica between 15 and 19. And for girls who sell sex, we estimated that there are 3,358 young girls in this group. Looking at the prevalence, and this we were able to estimate based on the subgroup within our larger national surveys. And for the prevalence among adolescent transgender, we estimated it at 27% based on the numbers we saw within our survey. Similarly, the prevalence among young men who have sex with men, 14%, and the prevalence among young females who sell sex, 2%. And so these are very high rates. And if you think back 2 slides ago when we talked about the actual population size, we can see that we're estimating that there are a significant number of adolescents who are in fact HIV positive. We see that the transgender Women or girls are at the highest risk and have the highest burden of the disease, and this is something that we hadn't previously looked in and disaggregated and produced estimates for, and so this also is another area that we were able to begin to acknowledge the need for further programming. This looks at the prevalence of preventative behaviors among adolescents. Based on the surveys, we have high reported condom use, so percentage of female sex workers who sell sex reporting condom at last sex over, it was 90% for female sex workers over 15 and 76% among young men who have sex with men. With the reported condom use among young men who have sex with men, we do have concerns just based on the level of STI and HIV seen in the population, and so as we move into our next survey, we are thinking of ways to better estimate that particular indicator to have a better sense of condom use and better understanding of the barriers to condom use so that we can work to that specific finding. Some specific data on our HIV testing, treatment, and care targets and how we're performing. For testing, we're below the established targets, so we're at 30% testing for girls and 18% of boys having tested in the last year. And so you can see the gender disparity, and earlier we had mentioned how surveillance data really painted a different picture of the epidemic among girls and boys, and I think this slide also shows you there is really a difference in access to testing for girls and boys. We're almost twice as the proportion of girls are testing compared to the boys. We have data on the ART coverage among adolescents living with HIV. So we have 31% coverage, and the target for that is 75%. And then PMTCT, and I mentioned earlier, this really has been one of our greatest successes in terms of the national response, and we have 98% coverage of adolescent girls for PMTCT. The next indicator is viral suppression, and for this we have overall 11% viral suppression among adolescents with HIV who are on treatment, girls at 8%, boys at 14%. One of the points to note about this data, however, is that this, the denominator for this would be the total number who are on treatment. However, the uptake of viral load testing is low, and so if we were to look at the percentage of the youth or adolescents who have viral load results, we actually have around 44% being virally suppressed, but it does indicate that we need to increase uptake of viral load testing, because as part of the treatment guidelines, really everyone who is on treatment should be getting viral load tests. And so, you know, this really shows two gaps: the achievement of viral load suppression as well as the uptake of viral load among adults. The slide looks at the coverage of key HIV/AIDS interventions among adolescents. So this speaks to condom use, and here we see boys reporting higher condom use, actually achieving the target, whereas girls, we still have a ways to go in terms of achieving condom use targets. The other indicator looks at cash transfers, and this one is at 63%. So we're moving towards achieving the target, but still room for improvement. One of the things this target doesn't look at the quality of the cash transfer, and so that's always something to keep in mind while the families are receiving cash transfer. How adequate is it? Because we do know that we've seen other data where we have higher rates of transactional sex and commercial sex work amongst adolescents, and it's something for us to look into as we move forward with the All-In initiative and look beyond these indicators to better understand them, how these different indicators help us to better understand the general picture. The next slide, coverage of key HIV intervention among adolescents. So this one looks at the comprehensive knowledge, which is another indicator that we do measure through a few of our surveys, the KPB as well as the reproductive health survey. And we have slipped. We've actually fallen back on the achievement of this indicator a few years ago, maybe 8 years ago we were performing better, but we're seeing this reduce. We're For girls 15 to 19, it's at 39%, and for boys, it's at 34%. And this is the indicator how, if they're able to identify transmission, how it's transmitted, as well as the myths around transmission. And one of the weak questions on this is the idea that having one faithful partner is a way to prevent HIV. And for much of our young people, when we do qualitative inquiry, we're told that no one has one partner, and so it's just not seen as an effective way to prevent because it's not something that happens. And so this is something for us to better understand, how to understand what the knowledge gap is versus what the sexual norm issues are that affect how they understand the knowledge and how this actually applies to actual behavior. So this is something that we're trying to understand better, and how we measure it versus how it actually plays out in behavior and how we're able to help them protect themselves. Media access, very high. It's at 96%, so it actually exceeds the target for this. So we have access to the young people. Everyone has access to television, internet, phone, or one of the above devices. The next indicator is cross-sectoral indicators among adolescents. STI rates at 5% and 6%, which is very high. So that's approximately 1 in 20 girls and 1 in 20 boys reporting having been diagnosed with an STI in the past year. Similarly, we have higher rates of adolescent pregnancy. At the time of the RHS survey, 9% reporting either being pregnant or already having their first child. The next indicator, maternal health, we have very good coverage. Well, that we are achieving the target on that, but it's heading in the right direction, and it shows that we have good coverage, ANC coverage among the adolescent girls. And similarly, higher folate coverage is not as great, and this speaks to some of the challenges that we've had with achieving some of our maternal health targets in Jamaica. And so looking at this data is also helpful in understanding where the gaps are. The other indicator on this slide speaks to mental health, and this, I think, was also another shocking finding for us when we look at the overall picture and the different, the picture that was coming together for the state of our adolescents. This indicator is suicide attempts, and here we're seeing average of 22%, with 23% among girls and 21% among boys, and this is very high. You know, as a local data point, as well as comparing it to what you see in surveillance studies in other jurisdictions, it is very high and definitely an area of concern. And for us to understand what are the factors that are leading to suicide attempts, what are the kind of stressful, traumatic, mental health issues that adolescents are grappling with that are not being addressed or not being addressed adequately, that will clearly lead to further risk for them, not just in terms of life expectancy, but quality of life issues that they may be contending with. The next slide follows up with alcohol use, and this is the portion of adolescents who have had a drink. I believe for this one it was by age 15, because this was done amongst a younger group, 13 to 15 year olds, and so between adolescents 13 to 15 year olds, 74% of girls and 85% of boys have already had a drink. And you know, alcohol use, risky behavior, suicidal attempts really all travel together, and so we see that there definitely is need for additional social support and more comprehensive interventions to address the issues that our adolescents are contending with. Next indicator is child marriage, and for this we have 8% reported in the survey. Sexual violence is remarkably high amongst girls at 21%, 5% among boys, but we know that in general surveys underestimate sexual violence, and particularly so amongst boys. So this is another area that we have to try and better understand and see what programming and what interventions need to be in place there. The next indicator, general education level, is very high, and so this is the percentage of girls and boys enrolled, and it's equivalent, 92% girls, 91% boys. This doesn't speak to actual successful completion or graduation, but it's a starting point where we know that equal amounts of girls and boys are enrolling in secondary education. This lovely slide speaks to the assessment of our enabling environment and lovely colors. But what it really says to us, this was an assessment looking at 4 groups of stakeholders: civil society, government or international development partners, and young people. And they were asked to assess different areas of adolescent programming and speak to the enabling environment for adolescents. And the 3 most striking gaps noted are national situation analysis, and I think I've mentioned it. We really did not have a good grasp of the adolescent epidemic or the impact of HIV on adolescents or just the situation of adolescents related to SRH. We haven't done a comprehensive review, and all of our stakeholders agreed and noted this in their assessment. The next area that was also unanimously agreed to was the adolescent participation. Everyone agreed that we can do a much better job. They were scored a 1 across the board, so the level of participation of adolescents was just not effective. And similarly, resource mobilization. Thank you, Jonathan. So the resource mobilization was marked as low. It's not effective in terms of the resources being put towards adolescent programming, and this has, I think, has worsened the current funding situation where we're really seeing the emphasis going towards our key populations, and without data to really say the impact of the epidemic on adolescents, we're not able to effectively advocate for resources to be put into adolescent programming. And so this is already being noted by our stakeholders. And so hopefully with All-In, we're able to pull together the data that we need in the coming months and really begin to make a strong case to have resource mobilized and targeted to the areas of greatest need amongst this population. That would be the end of the data slide. So to summarize, pick up on the last slide, the overall enabling environment is perceived as weak, which underscores the need for a platform such as All-In to really allow us to get a comprehensive overview of the situation with adolescents and begin to think of how we're going to target programs and how we're going to be more innovative and strategic with the work that we do with adolescents so that we can achieve targets around ending adolescent HIV and AIDS. The risk of HIV infection is evenly spread between adolescent males and females, and this, like I said, this was another eye-opening finding for us because previously, relying on surveillance data, it told a different story because it really reflected the access young girls had to HIV testing, probably primarily through ANC care, as well as overall disparity that we see in healthcare seeking behavior between males and females in the country. We saw the risk of infection appears slightly higher among young people. So with the onset of sexual behavior, we see different drivers coming into play. So risky sexual behavior among adolescent male and female, inadequate early targeting of program and enabling environment for protection, care, support, and prevention in vulnerable young people. We have issues and challenges with some of our national legislation and policies, and this will probably be discussed in a subsequent commentary, but those are some of the things that affect the programming we're able to do for adolescents and the access that they have to care in Jamaica. Point 4, the foundation for effective programming is strong. So there's a high level of access to media and information. So we have the means of reaching the adolescents. There's high reported condom use behavior among adolescent boys, could be improved among girls and also amongst our key population. So we really just need to understand that behavior, better reinforce it and seek to increase it. There's high coverage of transfers for vulnerable households. And there's a strong government-led multi-sectoral collaboration on adolescents that involves public sector, civil society, and development partners. This could be strengthened if you think back to the dashboard, but the foundation is there, and so it's really for us to now target the work that we do. Some critical interventions that need strengthening are HIV testing and counseling, the targeted interventions for adolescent key populations. I think once we got to the point where we started doing the population estimates for our key populations and then looking at the HIV prevalence, we really were made aware of the burden of the disease in these young people, and it really hadn't been an area of focus before because we hadn't really moved to trying to create a picture of what adolescent HIV looked like and the general overview of it. So I think coming from this, we're seeing that we need to strengthen these interventions. The psychosocial care and support really is striking as well, because we now see the issues around the suicidal ideation. We saw the issues around sexual violence and the high levels of sexual violence experienced by adolescents, as well as substance use. And so the need for a comprehensive program that talks about protection as we see, children moving through adolescence towards adulthood. What are the mechanisms for protecting them? What are the mechanisms for strengthening and ensuring that they have the support needed to transition and become healthy, productive adults? Data, some of the observation and gaps coming out of the rapid assessments. We have multiple rich data sources that were accessible. However, they were outdated, and so we need new data. And most critically, we need new data looking at adolescents. We haven't been able to conduct any adolescent prevalence surveys or IBBBS looking at adolescent 10 through 19, and this has to do with some of the policy barriers, some of the difficulties achieving or gaining ethical approval for these studies, and so that's been one of the barriers to having the data available. But this really is a need. We need to get updated data sources. Lack of disaggregated data for 10 to 14, this speaks to the inability that we've had to actually conduct surveys among this population and having to rely on surveillance data or clinic data, and the gaps that exist because of barriers to accessing care for persons in this age group. There are some differences in indicator definition across surveys. So, for example, reproductive health survey compared to the mix, compared to the knowledge, attitude, and behavior practices survey may have defined indicators a little bit differently, so people are able to compare the data or use data from one survey to the defined indicator. We had missing targets for a number of HIV and non-HIV interventions, and this is something for the national program to review as we move towards establishing a new strategic plan to ensure that we have appropriate targets and that they are targets included for different age groups, including adolescents. And then limited data on adolescent key populations, which is critical for us as we've noted the shift towards a concentrated epidemic, and with early onset of sexual behavior, having a significant proportion of adolescents in these populations being sexually active and so being at risk. So finally, concluding, the challenges amongst the most vulnerable adolescents extend beyond HIV. We're seeing the significance, for example, of mental health issues among. We are now clearly aware of the issue of the HIV epidemic, but it's beyond that. It's thinking about the different social circumstances, issues around. How are we going to comprehensively address these issues to ensure that we're giving adolescents the best chance they have to live healthy, productive lives? And I think, it's a summit of, we are seeing that from the data and from the picture that we're able to see. Cost of inaction will be high. We have to act. We have to address these gaps, and we have to do it in a concerted and strategic way. Thank you.
To give her presentation. If you have any questions, you may start perhaps putting them into the message box now, especially around the data and some. And as we are over to Lakeisha Black, whenever she's available. Can I ask our participants to please remember to mute your mic, ready to ask a question at the end.
Good morning again, everybody. Adolescent participation in decision making is not as effective as it should be in Jamaica. There are groups where youth and adolescent involvement is encouraged in communities and schools. We are also organized as some part of non-government organizations. Sometimes we are consulted through focus groups, but adolescents are rarely at the table when decisions are being made. Bottom line, our voices need to be heard. We must have a say in decision making surrounding us. About 30 adolescents and youth came together in April to share our thoughts about adolescent AIDS epidemic and how it is being and was being implemented. Among the group were adolescents in schools, adolescents living with HIV, heterosexual and homosexual adolescents, and teenage mothers. We noted that many other adolescents who are affected by AIDS or are vulnerable were not there with us. This was an important missing piece. We know that it is very important that all vulnerable young people are given an opportunity to share their views and give recommendations. One of our lively group discussions at our first meeting. We agreed that with all the laws in place and the policies that are on the books, adolescents are still being overlooked and are not a strong focus under the current AIDS program response. We agreed to engage other adolescents and young people to make sure that we are not just speaking from limited understanding, but as much as it is possible, ensure that the views of all vulnerable adolescents are heard. We agreed that adolescents were not being given enough space to make decisions, especially when it comes to our health, education, and overall development. We agreed to stick together. We intended to change that. We have kept the discussion going and keep each other updated through a WhatsApp group that was started the first day of our meeting. Since then, we participated in the national stakeholder meeting, which reviewed the data on adolescents. We participated in rating the policy environment and gave very useful feedback to the government representatives, the members of the All-In team, and all the adults that were there. We now have three adolescent representatives and 1 youth representative on the All-In Steering Committee. We are very committed and excited about our role in the country assessment and beyond. And what's next for us? We are now involved in the setting up of an adolescent technical working group, not just for All-In, but as a part of the National AIDS Response Team. We will be meeting regularly to improve our knowledge of the AIDS response and have discussions so that we can be ready to give our full participation at the steering committee meetings. We will be a part of a national stakeholder workshop that will make decisions regarding phase 2 of the country assessment. We will ensure that adolescents from vulnerable populations are taken into consideration for the decisions that will be made. We will also be an important part of the monitoring of All-In as it moves from assessments to strategy. Thank you.
All the energy of an adult. Thank you very much. We are now moving into our final presentation from Dr. Nicholas Skyers, who is a Senior Medical Officer in charge of the HIV
Yes.
Presentation.
Hello, Novia. Novia?
Yes. Are you hearing me?
Yes, okay. It's okay now. Please go ahead.
Oh, great.
Okay.
All right. I'm sorry. Let me just reintroduce in case no one heard when I said our next and final presenter is Dr. Nicholas Kyers, Senior Medical Officer at the Ministry of Health's National.
Okay, morning again, everyone. In terms of the lessons learned and the implications coming out of this assessment, as we had noted from our local data before, or KPB, as mentioned by Dr. Jarrett, the issue of the risky behaviors amongst our adolescents with regards to multiple partnerships, transactional sex, lack of consistent condom use, and low risk perception had increased when compared to 2008. She had mentioned also the limited information on adolescent populations generally, and especially for the key populations and the 10 to 14 age group. The structural and cultural barriers that we have facilitate limited uptake of prevention and treatment services, the legislative framework with regards to the age of consent, as well as the age of majority and the ability to access services without parental consent, the implications of the economic state of the country where persons are more socially vulnerable and as such will engage in risky practices, and also the issues around our social safety nets, which are spread very thin right now, and there's a lot of competition for these services, especially as the economic state declines. So key concerns coming from the rapid assessment: who, why, where. We note the need for an in-depth analysis of the estimates of the adolescent HIV epidemic. The issue with regards to the reliance on antenatal data has certainly shown that that is not the most reliable mechanism for measuring what's happening within our youth population. The issue of uptake of HIV testing and counseling in view of the risk behaviors, issues of access, stigma and discrimination, and the legislative environment is clearly a priority issue for the adolescent AIDS response. Linkage to care, again, the uptake of antiretroviral therapy and adherence to treatment in that entire adolescent period that has its own intricate challenges, certainly give us food for thought in terms of how we maintain linkage and retention in care for our adolescent population.
Are you able to hear us?
There are some interruptions, but yes, we can hear you now.
Okay, all right, thank you.
So data on key populations, in general, it's limited, and certainly we have challenges with our underground adolescent populations. So we need to do some significant work in that area to be able to fully define the adolescent HIV epidemic. The 10 to 14 age group, again, in terms of the data, service uptake, provision of services to meet the needs with our legislative challenges is something that we need to give some focus to. And as Dr. Jarrett mentioned, mental health and the need for early detection and response as part of the mix of services for adolescents, given the data previously presented. Concerns: we need to ensure for an effective response, we need to ensure that the adolescents are involved, and as Nikisha mentioned before, the adolescents are demanding a collaborative approach, and we certainly are receptive to that. The responsibilities are far more than the health system can cover. The inclusion of adolescents, education, youth, and civil society as a whole will certainly strengthen the approach and the successes from this process. Lessons learned, government buy-in, leadership is critical. So to have all the partners at the table, inclusive of the leadership role of the PI Planning Institute of Jamaica in pulling the team together. It's important in terms of the high-level engagement and buy-in, and we have a little bit of work to do with regards to getting some other sectors at the table, but it was certainly important to have all the relevant government bodies involved in the process. The participation of adolescents is a key component of the work, and we're learning to do this better, and Nikisha was quite eloquent in her presentation. Secondary data analysis, it takes time. The steering committee has actually formed an M&E subcommittee who will certainly help to strengthen the data sources data for the response as we move forward. All-In is not all things for all adolescents. It's really seeking to address the adolescent AIDS epidemic, but we certainly hope that we'll have a positive spin-off from this in terms of the collaborative approach to adolescents in general. The critical stakeholders are all represented through the steering committee, and through this mechanism we have pulled together a strong lead team which has not necessarily been at the same table, but we now have a common understanding and the interest around the well-being of adolescents, and it behoves us to move this forward into phase 2 and beyond. And it's envisioned that we will continue this very valuable partnership beyond this process. Phase 1 will be completed and closed by the end of next month, with the prioritization working group workshop involving the steering committee and other stakeholders to determine how we move forward into phase 2. The adolescent technical working group will be put together as part of the National Family Planning Board's Human Rights and Enabling Environment, and this should be pulling on the wider Ministry of Health's adolescent technical working group to see what lessons have been learned through that process as well to strengthen moving forward. And the way forward, the end result is a better articulated strategy for the AIDS response amongst the adolescents and will feed into our 90-90-90 targets. The country assessment forms part of the process to achieving Goal 1 of Vision 2030, which is a healthy and stable population. And Jamaica is better equipped to pursue targeted and evidence-based advocacy and action around access to adolescents and other key bottleneck issues that are identified in this process.
I want to thank all of our speakers for their efforts, their time, and putting the presentations together, and then for really strong delivery of the presentations. We invite you to ask whatever questions. I don't see any yet. And I also want to acknowledge other members of the steering committee for All-In that are in the room, and also the UNICEF Deputy Representative, Lone Hivas, Dr. Denise Chevans, who is Executive Director of the National Family Planning Board, Sexual Health Agency, our colleagues from the Planning Institute of Jamaica, Ms. Denise McFarlane and Deidre Coy, along with the other speakers in the room, and some of our other supporters I see have also tuned in. Welcome, Dr. Evans Gilbert. It's good to see you. And I would like to just open for the questions. And I see Dr. Evans Gilbert has asked what is the next step, the phase 2. Dr. Jarrett, would you, or Dr. Skyers, would you like to say about how we're moving forward with phase 2? We also have a question for you, Charlene. How readily available was the data on young TPOPs?
Okay, as mentioned during the presentation, we'll be having a prioritization workshop in June, and other relevant stakeholders will be participating to determine how we strategize for phase 2. The Adolescent Technical Working Group, also as part of the National Family Planning Board, will start and continue its work in this area. So those are the two short-term activities moving forward.
Into the issues that have why is the uptake of testing
Hello?
Yes, hello?
Okay, yes, please.
Hi.
We lost you for a second, sorry.
Oh, okay. Are you able to hear me well now?
Yes, please go ahead.
All right.
Hi again. So in response to the question, how readily available was data on young key pops, we were able to disaggregate the data from our 2 national surveys. The MSM survey, we had, I can't recall the specific sample size, but we did oversample on younger persons in both studies. And so we're able to disaggregate the data sets and able to analyze to get the data for MSM indicators and for the sex work indicators. The data sets weren't readily available. So I think some of the gaps that we have in providing that information is because of the reliance on the principal investigators for the study to supply that to us. So I think one of the lessons from that is to ensure that more robust data sharing agreements are established when these studies are conducted, so that we'll have these data readily available as we need to explore them to better understand these issues. And I think this also refers to the second question in terms of what methods were used to collect the data. So, we did secondary data analysis of the existing surveys. We pulled the data sets and went through to try to best get the data for the key population specifically. For the other indicators, for example, non-HIV indicators, the consultant contacted different agencies, stakeholders, and pulled reports from various studies, and we went through those different reports to identify the indicators of interest, and that was the data that was used. I'm sorry, let me get closer to the mic. Still on yes, so we do want to do a better size estimation for the adolescent key populations. And if so, what would you suggest on getting this done? We have RDS, we're in the process of planning RDS study for MSM. And so what we'd like to do from that is to be able to get a better estimate of adolescent population for MSM. And it is through the conducting the MSM survey that we'll also be able to access transgender population. And so we hope to have a better estimate of the transgender population and for the young MSM population through this study. We're about to embark on the formative assessment next week. And so we'll be doing a lot of thinking on exactly how we're going to implement this and what strategies will be effective in estimating the population. So we're in the process now of planning it and moving into the formative assessment.
Any existing sociological that has been done to
That's a great question. I think in looking at the findings, we are keenly aware that there are these bodies of knowledge out there that will help us to better understand them. But in the rapid assessment phase, it really was pulling on the quantitative data. And so moving into the next step, that's exactly where we need to go to look to see how we can better understand these links, but it's not something that we've done. We did as part of the rapid assessment, but we fully appreciate that we need to look at sociological, anthropological work to better understand it and to think of, how to structure that comprehensive approach that's clearly needed to address the issues that were revealed during the all-in assessment.
Then from Christy, we have a question regarding focus groups at the school level.
The focus group. Yeah, the focus groups are around the data validation, and I'm looking at UNICEF, so for the youth.
Really what we wanted to do, we didn't do any focus groups at this stage because we really were looking at data that we already have and to be pulling out the picture of the adolescents at that stage. And we believe that once we embark into phase 2, where we're digging deeper at those issues that have come up now, in order to understand what are the key bottlenecks that have come up clearly in the rapid assessment, that is where we're going to now have to go to different groups and pull, data around qualitative and data around what the issues really are.
Yeah. I think that really is phase 2, is now that we see these findings, is how to better understand it and contextualize it and see the links between the different areas
in order to strategize.
Yeah.
So thank you, Eric. Good luck in Kenya. We're on email. We will be sharing in the community of practice. So thank you very much, and thanks for if you need to reach out to any of us, we're happy to answer any other question you may have. Verity in Lao, where we conducted a similar survey with peer networks of MSM and girls and boys who sold sex to better understand vulnerabilities and possible opportunities to find solutions. Key to the question, how do you promote harm reduction with 10 to 19-year-olds? This is harm reduction strategy, including condoms. Thank you. It's very useful, Verity.
Because we had a discussion yesterday around harm reduction strategy and thinking how it would apply to our specific employment, so that's very useful.
Any other questions? Comments? I think Najeen, yes, we will be posting in the presentations will be there for you through the community of practice. And any questions, any further questions, can reach out to me, and I can also direct it to the rest of the steering committee. And for us, I think I can say that this has been a truly very exciting endeavor, and All-In has really given us a kind of a new life where we knew that we needed to get to this point, but All-In really has been the vehicle to help us to get to the point. So want to thank all our supporters and the rest of the external team in New York and at our regional office in Panama. Thank you so much for your support. And Christy says, based on the gaps and limitations identified, were any recommendations made, especially in terms of the mental health issues raised? I think what the mental health issues are pointing us to that the adolescent must be considered around a variety of vulnerabilities. It is really not just yes, we know that there are the high impact interventions and so on that must be considered, but we also have to look at the whole adolescent. And clearly that is pointing us in a direction where the strategy has to include the mental health needs of the most vulnerable populations. Verity, how do you anticipate that you will address the issue of stigma and discrimination within the health sector to serve the needs of a 13-year-old MSM? That one over to Dr. Skyers, our health system link on the steering committee.
That is a difficult one. We have had significant challenges with respect to stigma and discrimination generally, and it's also multi-layered when you add the issue of youth in that regard. There is continuous training for our healthcare workers with regards to stigma and discrimination. And in the last year or so, we have partnered with JFLAG, one of our local LGBTI lead agencies, and they are also within the health sector, in the health facilities with the healthcare workers, having an intensive training to address some of these issues so that the young MSM and MSM in general are able to access quality service as we seek to through addressing the S&D issues. We have been having positive feedback from our HIV treatment sites, and as such, we anticipate that this continued process with the training of the healthcare workers will certainly increase their sensitivities with regards to MSM and also our youth. And there is also the legislative process that we are currently engaged in trying to increase access to services for our minors that would certainly alleviate some of the challenges that our healthcare workers face in offering care to persons under 16. So we are in a process, and we have collaborated with the significant partners, and hopefully through those processes we'll be able to offer quality care to that 13-year-old MSM when he engages with our facilities.
I also want to acknowledge Dr. Evans Gilbert's input. Great work, feeling the ball rolling regarding mental health. Psychologists in our adolescent clinic have been key in helping adolescents navigate adolescence and improve adherence, and contraceptive clinics are indeed. We are also acknowledging Christy's congratulations to Nikisha and her group, making sure that adolescents are involved and engaged in the process. Thank you very much, Verity. One love to you too. I'm again just want to underscore that this has been a tremendous team effort. The steering committee has been very committed. I want to also acknowledge my UN sister agencies, UNAIDS in particular, UNFPA, UNDP, UN Women, and everyone has really taken this on in a very serious way. Kate didn't mention that All-In is actually on the work plan of the UN Joint Team, and our RC is also very well briefed, our resident coordinator, on our progress and has given us his strong support. I want to also speak to the coordination role of the Planning Institute. I think Dr. Skyers touched on it, and how critical that has really been in helping to bring partners together and to keep us, even as we bring technical experts who are on the ground, to keep the higher level engaged in this process. And once again, to our colleagues in UNICEF New York, and our regional colleagues, Jose, Ralph, and our sisters and brothers in Haiti and Brazil from this region, who are all trying to move together in a cohesive fashion and supporting each other through this experience. Thank you all for tuning in. And I'm not sure there are any more. Thank you, Beatriz. Congratulations. We will be offering our congrats to you as well soon. Thank you all. Najeen, can I hand it back to you?
Thank you, Novia. Thank you so much. Thank you, presenters, national colleagues in Jamaica. We heard about the experience of Jamaica. Very briefly, if we can wrap up, we heard from our colleague in UNAIDS on the issue of multisectorality of the process, how it was government-led, and also the involvement of different UN agencies. Then we heard from Dr. Jarrett some of the key findings. the issue of the treatment, the good results of treatment, the prevalence, 27% among transgenders, 14%, and the 2% female sex workers. And we also, I think in her presentation, we learned about the situation of mental health and how it's important that some key actions be taken in that regard. We heard from our young adolescent participant about the issue of the need and the importance of the diversity of adolescent involvement throughout the process, not just from certain groups of adolescents, but also from adolescents in key populations. And we also heard from Dr. Nicholas about the next steps that Jamaica is planning to take. More important of all of them, the importance and the next steps in terms of adolescent technical working group. I think that would be an area of interest to all the countries that are involved in All-In and all the countries that are doing HIV prevention, treatment, and care for adolescents. So we hope that we will keep on this dialogue through community of practice. Please stay tuned as we are soon going to be posting the reports from Jamaica on the community of practice. I have already shared the links with you in the chat box. The recording and the presentations will also be shared through the community of practice. So we encourage everybody to sign up in case you would like to get notifications and have access to all these resources. We will be back soon, hopefully, with the next country experience, and so stay tuned. And if there are no further comments or remarks from our colleagues and partners in Jamaica and from the participants, we can close this session. Is there any comments, Novia?
Yes. Kate would like to say something.
I think that in this region, in the Caribbean region also, there are some pockets of good things going on. So I'm very happy to see Beatrice there. And I think Jamaica can have a conversation with the experience for reaching to adolescents in Haiti.
Thank you so much. Thank you for this additional explanation. So if there are no further questions, I think we managed very well in terms of time. So if there are no further questions from participants, we can close. I see some people still are typing. I have shared with you the link of the community of practice. You can sign up to get the full report from Jamaica and also continue on some of these discussions that we've had on different aspects. So I think we can close. I don't see any specific question or comment. Yeah, okay.
Thank you so much. Thank you, Felix. Thank you, Jonathan, John. And thanks to all. And once again, I just want to say our experience is there for us all to learn from, and we are willing and ready to answer any other questions that may come up after this webinar. So through the community of practice, through my own email, ncondell@unicef.org. Thank you, and of course through our headquarters and regional. Thank you so much.
Thank you, Novia. Thank you, and I wish you a nice day.
Thank you. Thank you.
Bye.